Good afternoon, everybody. Thank you for staying for the last hour, and I hope we can make it worth your while. I'd like to just start off by saying I'm part of one of the 10 advisory groups that was mentioned earlier today, and I co-lead it with Christina Hayhurst. She sends her regrets. She was unable to join us today, but our group works on opioid-related harm. And we have two sessions that are directed at that one. This first one this afternoon is focused on healthcare professionals. And then tomorrow, another session on devices. We have a blockbuster lineup today, and I'm really honored to sit in the same row with these guys. And they're going to talk to us a little bit about how professionals can influence opioid harm. You see the lineup here on the screen, and for the sake of brevity, dispense with the introductions, and we'll just go in the order that they are up there. I will say that tomorrow we have a breakout group that's focused on preventing opioid harm. I'd like to invite all of you that are interested to participate in that as well. And I feel like this session will help get our creative juices going, so we might be able to come up with some good ideas to move forward in preventing opioid harm. Okay, without further ado, we'll just go as we see on the screen there, and we'll start off with Dr. Brummett.
I'm glad you're going to do that because I wasn't going to find it. You can be there. Hi, everybody. It's a pleasure to be here today. I'm Chad Brummett. I'm an anesthesiologist and a pain physician at the University of Michigan. I'm kind of allergic to podiums, but I've been told I have to behave because of online efforts today. I'm going to go pretty quickly today, talk about the work we've been doing over the last 6 years, and probably just cover a little bit of it. And just by way of disclosures, these are some of my recent and current grants. And also importantly, I consult for a few companies. I won't talk about any products. I do a little bit of expert testimony, and I have a patent that has still paid me $0 to date, but is for sale if anybody wants it. I think my biggest disclosure was that I was born, and I got very excited when I got invited to the Robert Stoelting conference, because I was born in the great state of Indiana in one of Indiana's greatest years, the last national championship team for basketball that went undefeated still to this day. And so I thought I was destined to be a basketball player for the rest of my life. But unfortunately, I'm a power forward stuck in a guard's body. And so my love for Indiana has never waned, though. This is me after Indiana won the last Big Ten championship at Michigan. I wore this to my office at the University of Michigan just to sort of razz my colleagues. But I think importantly for me, for Dr. Stoelting, he won't remember this, but I remember being this little medical student who needed a letter of recommendation of residency. So I call his office, because this is back in the day when you called people. And I call expecting to get an administrative assistance, and immediately, Bob Stoelting. And I thought, I froze. I didn't know what to say. And he said, "Oh yeah, Chet, nice to meet you. Sounds great. Why don't you come down to the operating room now? I'm in my office." I said, "Great." So I walked down there, and Dr. Stoelting had a really nice, beautiful office in the dean's office, but he preferred his office near the operating room with this awkward partition between him and his admin. They just sat in that office, and he worked because he liked to be part of that. And I will forever be grateful for Dr. Stoelting. He would not pick me out of a lineup today, but I'm appreciative, and I'm still a proud Indiana grad. So I do a lot of work thinking about opioids in a way that a lot of anesthesiologists don't. And really, this is how our group started. Why do surgeons prescribe so much? Now, I'm a pain physician. I could replace myself in this image and say, why do anesthesiologists prescribe so much? Why do pain physicians, dentists? We could really put anybody in this picture, right? And we heard some powerful stories here earlier today. I would normally start with a story, and I'm appreciative of those stories because stories do drive what we do, but these are true factors, right? And these have been shown both informally through conversation, but also through formal qualitative studies. People prescribe because they're concerned about time, they're concerned about phone calls for refills, patient satisfaction, and reimbursement still matters. I still care that people go back to their primary care physician and say, hey, Brummett's a good guy, send in more patients. And so because of these factors, I could be driven to prescribe more. But thankfully, our group and others, you see Brian Bateman up there, have done a number of different types of study with different types of data and pretty clearly in all cases shown there's no association between the number of pills prescribed after surgery, after dentistry, after multiple acute care episodes, and people's satisfaction with their care, nor is there an association between the amount of pills prescribed and likelihood of refill. People call for refills. The thing about it, though, is it doesn't matter whether you prescribe 6 pills after an abdominal surgery or 60. The line's pretty flat. Doesn't matter if you risk adjust or don't. In fact, after total knee replacement, once you get up to that 150 pill level versus the 10, you start to see higher rates of refill, probably because people are becoming dependent and withdrawing as they stop. They're taking it more. And we've done a lot of work. We were talking about social psychology earlier, this concept of anchoring and adjustment. I had seconds for lunch. Right? I don't normally have seconds for lunch, but the buffet was there. I came back, I had more. I would have been satisfied with 1 plate. We're giving a lot, but we're not necessarily satisfying people more. They care that we call them, that we attend to them. And then that same way, if we take a Saturday afternoon where we get a call and we have to refill and we start changing our prescribing, we're not doing something that's evidence-based. Now, our group at that time was actually really interested in this concept, and some might take issue with our percentages here or our rates here, but I was really interested in this concept. How often does a person coming in not using opioids before surgery go on to become what I would call a new persistent user? So not necessarily describing opioid use disorder or addiction, but somebody who wasn't taking opioids and continues to fill opioids long past what would be deemed normal surgical recovery. And despite the definition you use, this is a real thing. This is a real problem, and it goes across all surgical conditions, and it goes across all patient types. And in fact, it's not just post-surgical pain. Most of my NIH funding is under phenotypic and genotypic mechanisms of who develops post-surgical pain. But actually, this overlapping Venn diagram between post-surgical pain and opioid use, chronic opioid use, it probably sits like this. There is some overlap, but they're very different concepts. And I just give you one example, that second line there, the Gessling et al., the total knee and total hip replacement prospectively collected data. And whether your knee or hip got better, worse, or stayed the same, that wasn't in any way associated with your likelihood of dependence. So what are those factors that we see consistently? And these go across, again, many different data types, many different studies. Anxiety and mood disorders, a lot of people, you will stigmatize that and say people like to get high, but actually if you talk to people in recovery who had childhood anxiety, they will talk about opioids normalizing or making you feel normal level. Our PACU nurses have known this for years. They are giving opioids for pain, but a lot of times you see them treating anxiety in our recovery units. Sleep problems, we've all had that family member say, oh, you know, my pain's fine post-operatively, but it's helping me sleep. But the problem is these aren't very good sleep medications. This is like drinking to sleep. You'll sleep, but you won't have restful sleep. Remote opioid use, this idea that we know what you're taking today, but have you previously been dependent or ever used opioids regularly? Okay, that's an easy concept, but an important one, because ultimately, if you have demonstrated that, you've demonstrated the ability to tolerate opioids, which about 80% of people cannot. Chronic pain conditions, again, seem obvious, but 1 in 3 Americans lives with chronic daily pain. Most are not taking opioids. They come in, they may have an abdominal surgery, and they keep taking opioids long after because maybe for some short period of time, their back or their knee pain is better, and we're not asking them why. And subsequently, the substance use disorders I'll talk about in a minute. Now, I've been told by, we've had critics over the times who've said persistent opioid use is just a couple pills now and then. It's really not that big of a deal. Why are we making such a big deal out of it? And so we've now published a number of studies, and other groups have as well, looking at this phenotype of continued opioid use, and shown that it is associated with development of a frank opioid use disorder, subsequent overdose. It is associated with the only genetic finding that's been consistently associated with opioid use disorder or addiction, with the OPRM1 finding. Death, healthcare costs and utilizations, falls, readmissions. If I showed this to any hospital administrator, they would be interested, right? So this is a meaningful outcome. Now, our group, we just talked about sort of this iterative process, this implementation science process. We've used that process with hospitals across the state of Michigan, 70 hospitals, multiple quality collaboratives, largely funded by Blue Cross Blue Shield of Michigan, to come up with a series of, not comprehensive, but a series of prescribing recommendations that were recently recognized by the CDC guidelines, and actually do meet leapfrog quality metrics as well. And you see this 0 to a number. That number is sort of what we would say is the upper bound, generally the 75th percentile of what people use. It has decreased over time because we give them less, they take less. Satisfaction and pain stay the same. And so we've done this over time. and we continue to update these. And this is just from one of our quality collaboratives, general gynecologic and vascular surgery. You see that before we started working, about the average was about 45 to 50 pills for, say, like an abdominal surgery. We started just asking people to measure their prescribing, and we see a decline. We didn't tell them how much, but just look in the mirror, and they started to decline. That's not surprising, but we do see significant declines after we released the first evidence-based prescribing recommendations for surgery in October of 2017, and then this starts to level off such that now we're prescribing on average about 12 pills, 10 to 12 pills for this case mix. And in doing so, this dark black line here shows you the decrease in prescribing in our state. And these data are from about, I think, 30 or 40,000 patients across 60 hospitals in our state. We see a decrease in prescribing. We see with that dotted line, a decrease in consumption, with pain remaining low and flat and satisfaction remaining high and flat. Didn't come in with the perfect multimodal protocol. You start messing with somebody's soup recipe and they don't want to play. We just sort of said, hey, this is how many pills to prescribe. And I have to say, this went better than we expected it to, right? We did not expect this to go that quickly. Now, everybody in the hospital, everybody in this room, your hospital has changed prescribing. I get it. I know it. We looked at Medicare data. We used a difference in differences approach. This is an econometrics approach that acknowledges there's change in the world. Things are changing over time. And we compared the 49 states to Michigan, and I should flip colors. Michigan here is in orange, not in blue. This is the before Harbaugh. This is the Michigan versus everybody slide. But we see clear, after we released our guidelines here in 2017, declines in prescribing that were significantly different and significantly faster than the rest of the state, such that we are prescribing about 11 pills less per case in the state of Michigan when compared to the rest of the country. And we have reduced the amount of persistent use in our state by an additional 0.5%. May not seem like a big number, but we're here talking about quality and safety, and 0.5% with those outcomes is a meaningful number. We have moved, we have transitioned, and in the last couple of minutes, I'll just tell you where we're going. This was maybe easier and faster than we expected. I'm not saying it was easy, but we've been effective. We've been really pleased with our partnerships and all of the people that we've worked with. So now we're starting to think about these harder pieces. Maybe where we almost started. How do we screen for substance use disorder? We're giving everybody a controlled substance, but we're not asking people about their own substance use history or their family history. We're not communicating between prescribers, and we're not coordinating care. And I just give this as one study. This is from Puccia Lagasetti. This is using a private payer claims database, national database of people who we would call chronic opioid users, people who used opioids month over month. 90% had a usual prescriber, someone who prescribed to them most months. Only a small portion, 30%, actually went back to that prescriber within 30 days, right? So this is a person who's normally getting opioids. They go have surgery, and then they just the surgeon's taking care of it, I guess. And with that, about 75% had high-risk prescribing, lots of overlapping prescriptions, benzodiazepines, high dose, and multiple prescribers. These are problems, and this is probably something that can be fixed with quality metrics. Similarly, and this is busy, but this is a new paper from Ann Fernandez and Mark Bickett from our group. These are data from the University of Michigan, about 2,000 patients. We used a standardized screening measure, the TAPS. This is the NIDA quick screener. And what you see here is that we picked up a lot. About 2 in every 5 patients had some concerning finding. And this is not just tobacco, binge alcohol use, non-prescription drug use, and prescription misuse. And we've already shown that these are better asking a patient, especially in the ways that we ask patients. So a standardized approach could pick up more patients and allow us to start to link patients to care. I've only touched on a few things. If you're interested, you can go to michigan-open.org. We're doing a lot of work with naloxone distribution, policy work. We have a musical for high school students that we've been testing across our state, and are working on other things. I want to just give a quick shout out to our team, hardworking bunch, really incredible group of people, my co-PIs, a couple surgeons, another anesthesiologist, and an epidemiologist. Thanks.
Good afternoon. I'm Toby Weingarten. I am a professor of anesthesiology from the Mayo Clinic, and thank you for staying around on this beautiful day, and thank you to Arnoley Abcejo for inviting me here. I'm going to talk to you today about postoperative respiratory depression, with a focus on how the phenotypical presentation and when the temporal distribution of these events occur after surgery. So when we talk about respiratory depression after surgery, I think it's important to understand this continuum of severity of this. It could be, mild self-limited respiratory depressive episodes, may even be just a slight exacerbation of underlying sleep apnea. It could progress all the way to death. When we look at the more mild cases or self-limited cases, the Sun-Z paper from the Cleveland Clinic showed about 37% of patients had spells of hypoxemia less than 90% for greater than an hour. When we used capnography with the Prodigy trial, we found 48% of patients had respiratory depression. Now, these were mostly self-limited episodes. When we're thinking about more critical episodes, if you use naloxone as a substitute, there's probably an N of around 850,000 patients who've been in cohorts where they've looked at postoperative naloxone on the wards. And it really comes down to about 1 in 1,000 patients is the incidence of somebody is discharged from the PACU, they go to the regular floor, and they get naloxone. Now, when we looked at capnography, the Prodigy trial, we looked at 7 countries, 3 continents. We had 1,300 patients enrolled. And again, we found 48% patients had respiratory depression. And we came up with a prediction model using 46 different risk factors that we looked at. What was very interesting in the Prodigy trial was how respiratory depression presented. So you'll see in those lines there, the blue lines are exhaled carbon dioxide. The red line is SpO2 from a pulse oximeter, and the green line is the heart rate. And you'll see that the patient is having normal breaths, exhaling in the CO2 in the mid-30s to 40s range. But then there's these gaps of partial apneas or total apneas. And this patient is on room air. So you see these very nice declines in the SpO2 associated with that. When patients are on supplemental oxygen, you can see that the SpO2 remains normal despite apnea patterns. When we looked at the most common pattern that patients had, 97% had some component of apnea. Okay, they do this over and over and over again. These are 4 examples of the Prodigy. The top left shows your typical apnea pattern with decreasing SpO2. The top right shows isolated bradypnea. And this is what oftentimes textbooks suggest, or what I think nursing staff look for when they're assessing patients for opioid depression. This was extremely rare, less than 1% of all the respiratory depressive episodes we saw in Prodigy. People don't typically do this. And you can tell it's kind of spaced out breaths. Very, very, very uncommon. The bottom slide shows a patient has a very profound apnea. Their underlying SpO2 is low, so there's probably an underlying degree of VQ mismatch, probably from atelectasis. And this patient has a prolonged hypoxemic response. The last one is really interesting. This is one we actually captured somebody getting naloxone. This patient had over 20 episodes of apnea before the naloxone was administered. And it's very interesting when we read the adverse report for that. The adverse event report was that this patient was having somnolence, not respiratory depression. So this patient with capnography is clearly having episodes of apnea, but the healthcare providers did not appreciate that. So what do most healthcare providers see? Well, if you look at the Lee study looking at closed claim events from opioid-related harm, somnolence was appreciated 62% of the time. We've done several studies at the Mayo Clinic looking at postoperative naloxone. And we see that frequently sedation is appreciated by the nurses, sometimes more so than respiratory depression. Why is that? Well, we conducted a simulation model at Mayo where we took floor nurses from a standard surgical unit and we had them assess a model that was either having apnea pauses or just isolated bradypnea. The first thing the nurses did when they walked in the room was wake up the patient. Hi, Mr. Johnson, I'm nurse so-and-so. I'm going to assess your vital signs. If someone is sleeping and having opioid-related sleeping disorders and they're still able to be aroused, you're extinguishing the disorders. And they were unable to appreciate the apnea model in 90% of the cases. So what are risk factors for having respiratory depression? When we look at the Prodigy model, we found that age was the most important risk factor for having respiratory depression, especially patients over the age of 80. Male sex, opioid naivety, OSA, and heart failure. Now, again, the Prodigy were self-limited episodes of respiratory depression. When we look at the Mayo Clinic naloxone studies, we found certainly OSA increased the risk, debility increased the risk threefold, heart disease 2.5-fold. Having CNS disease, so dementia, Parkinson's disease, really increased a 4-fold increase. Also, patients using gabapentinoids were at much higher risk for having respiratory depression requiring naloxone than patients not on those medications. We focus a lot on obesity. I've never really seen an obesity signal. Probably it's the other way, with thin people are higher risk. Cachectic patients, patients who are malnourished, are higher risk for getting severe opioid-induced respiratory depression than big people. Who are you more worried about? I'm more worried about Guy's parents than Guy. Okay. The other interesting thing that we've noticed at Mayo is that the PACU can really predict who is going to get into trouble on the floor. And so I always make the analogy that the PACU is a canary in the coal mine. It will tell you when trouble's coming. The studies that we've done looking at patients who are having isolated episodes of respiratory depression in the PACU went on to wake up and then go to the floor were at 5-fold higher risk of it getting Narcan on the floor compared to similar controls. Patients who got Narcan in the PACU or in the operating room to wake them up also went on to have much higher rates of having problems on the floor than patients who did not have that. A study that I was not involved with, they used the bioimpedance monitors to measure respiratory depressive episodes in the PACU, and they dichotomized patients if they had problems at the beginning, at the end 30 minutes of the PACU, or not the end 30 minutes of the PACU if they had respiratory depressive episodes. And what they found is when you go back to earlier in the PACU stay, those who had respiratory depressive episodes the last 30 minutes were those who had respiratory depressive episodes at the beginning of the PACU. When you look at those patients after they left the PACU, they continued to have respiratory depressive problems for greater than 12 hours compared to the patients who did not. So this behavior in the PACU continues on the floor. These are some unusual 24-hour clocks we developed from the Prodigy trial. So these are 24-hour clocks, so it's midnight, 6 a.m., noon, 6 p.m., midnight. And as you go farther out from the center, you have higher rates of incidence. So the first one is, when did patients first start developing respiratory depression with capnography? The red line shows when surgeries were done. So in this trial, usually between 10 and 2, they were in the PACU not being monitored for capnography. When they went onto the ward and the capnography device was starting to apply to them, we began to observe apneas right away. When we looked at the cumulative, all the apneas that they had, we got this bilobed picture where we have a large number of events occurring in the evening and a large number of events occurring in the middle of the night. Okay. So which one is more scary? Which one are we more concerned about? We look at the Mayo data of when patients get naloxone, the same 24-hour clock, we see that the patients are mostly having Narcan shortly after PACU discharge when they go to the floor. So this respiratory depression in the PACU seems to really manifest on the floor. And why is that? Well, the PACU is a stimulating environment. The nurses are talking to you, there's machines beeping, there's a lot of action, a lot of activity. Now it's time, you've met PACU discharge criteria, now it's time to take you to the floor. They put you on a gurney, the guy is talking to you and you're bouncing up and down on the thing, it's uncomfortable. You show up in your room, your family's there, the nurse is checking you in. It's a very stimulating environment. Now they tell you, you've had a big day. We're going to go eat and we're going to let you rest. And they leave you alone. And that is when the patient falls back to sleep, becomes more somnolent. And then when the nurse goes and checks on the patient, very alarmed, calls an RRT, and patients get naloxone. So what to do? Well, I think it's important to understand your patient's risk factors and to minimize extrinsic risk factors. So extrinsic risk factors are things that we do to the patient. So maybe the frail patient, you should push that patient more for a regional technique than a general anesthetic. Maybe that patient should have short-acting agents rather than longer-acting agents. And I think it's critical that we educate the floor nurses and the PACU nurses about this interaction between PACU and floor respiratory depression, and to really train the floor nurses not to wake up the patients before they assess the respiratory rate. Also monitoring and triage strategies. The problem, and I'm not going to go too much into this, with continuous monitoring is there's ergonomic challenges, there's reliability, there's acceptance, and you have to integrate this into your practice. And we all know this is much more difficult than we think. One approach, though, which I like, is considering much more specific parameters and sensitive parameters. One group, they turned the pulse oximeter down to 80%. That would alarm after 30 seconds. Okay, so you have to be at low 80 for 30 seconds before it would alarm. The patients were instructed to take 3 big breaths if the machine beeped at them. By this, the nurses only got 4 alarms per day, and the rate of RRTs went way down. The rate of ICU admissions went way down. And further, the nurses were then able to focus on other patients and provide better care. So they did a model of this where they took more of condition-specific alarms. So they said, what would happen if the alarm beeped at 88% instantly? And we put a delay from 88% down to 80%. They had an 88%, I know those numbers are the same, but they had an 88% reduction in overall alarms. And then if they had a 15-second delay, they had another 71% reduction in alarms, which reduced the amount of alarms going off for the nurse from 1.2 hours per shift to 3.6 minutes per shift, so much more manageable. So this is a general approach that we use at Mayo to assess patients. And I think this can be used not just for respiratory depression, but many other factors, is that we need to assess patients and say this patient is either low risk, intermediate risk, or high risk. And then modify our surgical and anesthetic plan based on those patient factors. The PACU is critical for monitoring respiratory depression. The PACU is probably critical for other things too. If the patient is very somnolent in the PACU, that patient is going to go on to be somnolent on the floor. If the patient is agitated in the PACU, that patient is going to be agitated on the floor. If the patient is hypotensive in the PACU, that patient is probably going to be hypotensive on the floor. So look at your PACU patients, and then based on that, as well as the overall assessment of the patient, make some clinical decisions of what are the best options for that patient. Maybe the patient can go to the standard floor or discharged, or maybe this patient needs something more. That does not necessarily mean the ICU. It might be mean calling the floor nurses and alerting them that, listen, watch for this patient. I think this patient's okay, but really keep an eye on their blood pressure for, the first couple of hours. And of course, if a patient is on some therapy for a chronic medical condition, so with OSA, if the patient's on PAP therapy, encourage the patient to continue using the PAP therapy on the floor. So I know this was quick. I usually talk about this for an hour at a time, so I'm happy to take questions afterwards. Thank you.
There we go. Cool.
Thanks so much, everyone. Thanks to the APSF and the organizers for this opportunity to speak to you all about the association of intraoperative opioids administration with postoperative pain and opioid use. So I'm Patrick Purdon. I'm a professor of anesthesiology and bioengineering at Stanford. There we go. So a couple of disclosures. I'm an inventor on patents related to brain monitoring. I'm also a co-founder of Pascal Systems, but the support for this work all comes from the NIH. Yeah, up until about a year ago, I was actually here in Boston at Mass General Hospital. And actually, I've been a Boston person, let's say, for over around 3 decades. So I went to college at Harvard and grad school at MIT. And after that, I was at MGH. So it's great to come back here. I feel like I never left in some respect. And just another little bit of trivia. My son was actually born on Ether Day at Mass General. So who would have thunk it? It's great to actually,
be at this meeting and meet anesthesiologists who are really concerned about safety, because I realized that I've always known there's like a bond between anesthesiologists and engineers, but I realized there's kind of a one key factor that brings us together, which is that we're warriors, not warriors, but warriors. We are worried about what can go wrong, at any given moment, and I think that connects us in some way. And then maybe another thing that connects us is that we are dreamers too, right? We're dreaming about the next innovation that can improve things and maybe make us worry less. But we'll probably find something else to worry about. And that dream is what led me to move to the West Coast and be part of Stanford's innovation ecosystem. I was a biodesign fellow, as well as a Spark scholar this past year, really trying to learn about medtech and pharma innovation. And the way I like to explain it to my Boston colleagues is, look, I'm just undercover over there with those tech bros, and hopefully the story that ends up being told is one that is actually socially redeeming and has a happy ending. But in many respects, I still feel very much close to my Boston roots. And the story that I'm going to tell is actually a Boston story, because all the work and the data came from Mass General. And maybe to start it off, I'm not a runner, but a few years back, a buddy of mine got me into running. His name's Kurt, and so we were on some training run, preparing for like a trail half marathon. I think we were going to go like about 11 miles, but somewhere around the Newton Highlands, we took a wrong turn, and about 14 miles into a 10-mile run, I passed by Newton Wellesley Hospital, and I saw this, and that was devastating. Just seeing that sea of purple flags, and just understanding, the toll that the opioid crisis has had on our society, and the needless deaths that have come from that. And at that, I was already working on this problem at that point, but it really cemented, kind of brought home the urgency of it and the reality of that problem. And so clearly, the take-home message from seeing all those flags is that opioids are really bad. And we know that surgery and the pain that comes from that is a kind of major driver of opioid abuse. And as Chad has pointed out, a lot of that, comes from post-op opioid prescriptions to control pain. But if we were just to take those opioids away entirely, we would still be left with the problem that if you don't control acute pain, that can develop into chronic pain that leads to opioid use disorder. And the initial pain, let's say in the hospital after surgery, at discharge, is a major driver of who will go on to develop acute pain. So it's really important to control that acute pain in that perioperative period. So the question is, so clearly opioids are bad in that post-op domain, but are they actually bad in the operating room? And what we saw as we were kind of getting into this topic in the lab was that opioid utilization was going down over time at our institution, Mass General. And just for point of reference, ED50 for fentanyl is listed there. So I'm showing the effect site concentrations that we computed for patients in the study that I'll tell you about in a second. And so we wondered, could it be that that actually reductions in opioid use that are just kind of happening subconsciously because people are concerned about opioids in general, could that reduction in opioid administration actually be making outcomes worse? So we kind of ventured off on this study, and as an engineer, we're due to statistical signal processing, statistical things are kind of in our wheelhouse, but this was like a totally new kind of undertaking or adventure. So we looked at general anesthesia cases over a 4-year period just before the pandemic. And our exposures were fentanyl and hydromorphone predicted average effect site concentrations. And our primary outcomes were the maximum pain and total opioid administration and PACU. But we also looked at a lot of opioid outcomes in terms of consumption in hospital and later prescription refills that we were able to pull from our EHR. And then we did a causal inference analysis controlling for over 130 variables. So of course, if we just look for associations, we're going to be picking up a lot of confounds. On the other hand, a clinical trial, a randomized clinical trial would be the best thing you could do, but obviously we're not in a position to do that in tens of thousands of patients. So this causal inference analysis is sort of the bridge between those worlds where we can account for the effects of confounds and try to make actually a causal inference. In fact, when we wrote this paper, it was like the influence of intraoperative opioid administration, et cetera. But the editors forced us to go back to association because the only way you can really get the influence in a medical journal is with the clinical trial. But in other fields, causal inference is an accepted form of study analysis. So we looked at a host of confounding variables. So preoperatively, what would influence the amount of opioids someone got? So we looked at this host of patient variables, surgical variables, provider level variables, and thank goodness we had these machine learning tools like XGBoost that allows us to construct a propensity model and produce a propensity score that allows us essentially, marginalize out the effect of those confounds. And then based on all that, we then took into account different intraoperative case characteristics, different measurement facets that might affect the outcome variables. And then, of course, we included the exposure variables in our analysis. And at the end, we had to use a variety of models, and I'll explain those in subsequent slides. But at this point, I should talk about the team because for us, this was a kind of like totally de novo venture. And, usually in like engineering, machine learning exercises, you just go, grab this data that's sitting there and you're like, oh, what kind of questions can we answer with that? In this setting, what we did is we kind of came at it fresh, proposed this hypothesis, had that predetermined statistical analysis plan, and we had to go get that data ourselves from our EHR. And we had to learn the methods too from scratch. And so, we really needed a very committed, hardcore team to go after that. So this team was really amazing that worked on this paper. So let me get into the results. So one thing I want to point out is that the fentanyl exposures in terms of that average effect site concentration were kind of well below the accepted EC50 that you might find in say Miller's anesthesia or something. Another thing I want to point out is that the outcomes kind of had this zero inflated behavior where a lot of people didn't get any opioids in the PACU, but some did. And so we had to account for that in our modeling, and same thing was true for the pain scores. So let's get into the results. So I'll show this first as adjusted odds ratio. So what we found was that the folks who received more fentanyl in the operating room tended to have lower post-op pain and tended to have a lower probability of needing opioids in the PACU. And for those who did get opioids, they tended to receive less. And for hydromorphone, there's kind of a similar trend here, especially with regard to the probability of getting an opioid afterwards, but maybe the trend for the amount of opioids was a little bit less. And then looking at some other variables of these kind of long-term outcomes. So the people who got more fentanyl in the operating room tended to have a lower frequency of uncontrolled pain, lower incidence of chronic pain, lower rates of prescription refills, and lower incidence of a new persistent opioid use. And they didn't have any worse PONV or respiratory depression. And with hydromorphone, longer acting, we didn't really see those longer term, if you will, benefits to increase administration accrue over time. So with the long acting hydromorphone, there's a little bit different story. So those are odds ratios, but to kind of put those in real terms in kind of clinical units, if you will, we did a counterfactual analysis. We took that model and said, hey, what would happen if you gave everyone across the board, say 100 mics of extra fentanyl, just to kind of put it in some kind of scale. So with that 100 mics of fentanyl under this model, what we saw is that uncontrolled pain would be reduced by about 56%. In-hospital use of opioids, we reduced about 38%. Incidence of new persistent opioid use would be reduced by about 12%. Incidence of chronic pain would be reduced about 30%. And then there'd be no change, reduced hospital length of stay by about 10% and no change in PONV or PACU length of stay. So pretty good deal under that model. So we're doing some follow-on analyses now, looking at non-opioids. We have a post-op pain prediction paper that was published. And one thing we're looking at in progress is opioid timing. I'll just give you a preview of what that result was. So we, from our data, this data, realized that the fentanyl and hydromorphone administration was being sort of given in two ways. One was to either give them early or to give them late. And what we found, again, in a counterfactual analysis, if we took, like, with the same amount of opioids, but shifted everyone to the early administration, you could get a significant improvement in outcomes in terms of opioid consumption and, say, uncontrolled pain and other variables. So we started to think about why that might matter. So the concept of central sensitization came to mind. You know, I'm an engineer, and so I kind of remember the part of the med school class I took on pain, and I tend to associate central sensitization with like chronic pain. But just going back and, you know, kind of reading the papers, this central sensitization can happen really quickly. So here's the kind of the original paper from Clifford Wolf, where with 60 seconds of a really, injurious stimulus, you could get a sensitization that lasted hours. So it maybe makes sense that in that intra-op period, if you can control nociception and prevent say a sensitization from happening, that might have lasting benefits thereafter. And of course, opioids, if you administer them chronically over days to weeks, they can develop tolerance and a hyperalgesia. But in this acute moment, perhaps you could control this sensitization. So in the end, I think our analysis, though limited by a single side, but with a lot of data, suggested there may be opportunities to optimize opioid administration in the intraoperative period, and that also leads me to think that we really need to develop new technologies to kind of make that more precise and individualized for patients. So, thank you.
Thank you. Hi there. It's amazing. There's a few of you still here. I started the day at 6:15, bookending the day. So this is why I love this meeting, because you have a presentation which tells you more opioid is okay and perhaps good, and I'm going to tell you why it's not. And so I'm going to talk a little bit about some of the evidence out there, not just from our hospital, but from MGH itself, which suggests that reducing intraoperative opioid dose is actually a good thing. I'm going to talk a little bit about the concept of opioid overdosing. Now, Toby's work, has stood the test of time, is reproducible. There's clearly, this sort of picture of an overdosed patient who's excessively sedated, for instance. But it's a lot more than just that. And I want to talk a little bit about waste, what the risks are with waste and what the outcomes are with waste. And finally, a little bit about how we might overcome some of the barriers. We've heard several things today around overcoming barriers, but some of the data from Brigham and other places, MGH again, showing how we might actually change human behaviors with medications. So overdose, like I said, we've got one presentation talking about inadequate analgesia, got another one talking about opioid-induced respiratory depression just before me, and clearly there's a bit of this harm thing that we're really concerned about here with APSF, but there's all this other stuff which we don't know. There's still data on both sides of the aisle here. So how much is too much of opioids? That's an important question. How much is too less, I guess, from Patrick's standpoint? Not going to go into this in great detail, but this close claims analysis clearly showed that severe opioid-induced respiratory depression is associated with harm outcomes. And although the percentage of claims is a smaller one, the outcomes, the tightness of the relationship is actually pretty strong. Ashish and others showed in a Prodigy secondary analysis that even the occurrence of one respiratory depression episode, as Toby showed, in a 1 30-second episode, is actually associated with increased length of stay and costs in hospitals. And so clearly you're defining a phenotype of a particular patient, as Toby said, who begins to fail in PACU and continues to fail after PACU as well. And so this is also overdose, right? So it's different. It's not the kind of overdose that we're thinking about, but this is overdose as well. And finally, from years back, these data from Mass General, which clearly show in a very large retrospective analysis that there is a dose response curve for readmission risks after surgery. Now, I don't know if this is the cause or the effect. It's clearly an association. But as you give more opioid, and the difference in dose here for the quintiles is not very large. We're talking of things that you and I quite regularly do in the operating rooms or see in the operating rooms. And particularly in ambulatory patients, there is a signal for a very strong dose responsiveness. So what we did was really begin to look at harm and this dosing within the construct of error. This is the NCC MERP framework for medication errors. And we set about looking at what if we looked at these doses of intraoperative opioids as if they cause a problem, why shouldn't we be looking at it as an error? Now, we're not going to define it as an error. We think nobody's going in there saying, I'm going to use this dose and want to cause harm. But this concept we're trying to expand on here is what the incremental intraoperative dose is, and is it associated with these harm outcomes. The first harm outcome is an error that occurred that may contributed to or resulted in a temporary harm to the patient and required intervention. So these are things like post-extubation desaturation, postoperative nausea and vomiting requiring rescue treatment, postoperative somnolence or sedation requiring further observation of the administration of naloxone. And what we found when we plot out the probability of this outcome occurring, and on the y-axis against the dose given with equianalgesic dose, we find two important things. First, morphine has a very impressive dose response characteristic, right? So it's not a drug we use in our formulary right now for intraoperative, and perhaps it's good that we're not. The second is that hydromorphone clearly sits a clear 5% above fentanyl for these patients. And we're really interested in, this was across all patients, we're really interested in ambulatory patients because that's really where the signal we're getting is. The second outcome of interest for us was that there was temporary harm to the patient and required initial or prolonged hospitalization. So this is category F, and we looked at delayed discharge related to clinical causes, predefined clinical causes. And this was an outpatient outcome. And other things we looked at were unplanned admissions from outpatient to hospital. We also looked at patients who were admitted to the hospital, delayed discharge from the hospital. And then finally, we looked at readmissions, and this was a composite outcome. And what's striking here is that even with very subtle doses, and here we're looking at patients who got the drug. Now, we're not looking at zero fentanyl or zero opioid patients. We're looking at patients who were exposed to morphine or exposed to hydromorphone or fentanyl. And the controls were more than 0 to less than 0.5, 0.5 to less than 1, less than or equal to 1, and 1. And you can see there's a clear dose response for each of these drugs. And so that suggests that there is at least a modest or even a strong relationship with the outcome of interest here. The pragmatist in me says, looking at this and looking at the data from other sites, that lower intraoperative opioid doses are associated with measurable, reproducible value. Now, you have to take this with a pinch or a sack of salt, based upon what Patrick has said. But with the data that we have from 2 large centers, 3 actually, if you look at the data out there, that it's associated with reduced early postoperative complication rates, reduced healthcare utilization, and some cost savings. Next, I want to jump into opioid waste, the hidden risks and costs. For this, we did a projected waste analysis. What we did here was we said, based on the dose that was given to a patient, instead of what was there in the OR on that day, what if we had, commercially available RTA preparations on that day, right? How would it stack up? And for this analysis, we had about 170,000 patients. For the costs, we also included the time that it would take to prepare a vial, and also the time it would take to waste a drug. Now, early in the day, I think it was Elliot or somebody who said, some people really don't care. We're going to pay anesthesiologists and CRNAs a flat salary. But we also heard from Amy that the overall sort of work that we do in a day, the complexity of the work that we do in a day, impacts things that we're not measuring right now. And what we find with the projected product size and waste is that we have about a 40% unit dosing with hydromorphone. So there's, for a 1 milligram hydromorphone, we've got about 60% of the times that it's used in the operating room, there's waste. Okay. Similarly, for fentanyl, that number is about 45 to 50%. And so together, you can see there's a large amount of waste that's happening in the operating room. If I project this across the whole of America, we could fill every year, I think, a 737 or a 747 with fentanyl and hydromorphone. Right. These are both drugs with a tremendous amount of potential for shortage, as we've all experienced in the past. And we look at the product size and cost. For us, it's about $75,000. It's not a large amount of money, but it's still important for us to factor. And if you consider the entire time and the effort involved, really it's equal to or slightly less than if you use RTAs in this projection analysis versus vials. When you look at predictors of intraoperative waste, you're thinking, maybe they're using less opioids because they're using adjuncts and other things. Really, the big thing that's sticking out is more than one opioid. The second somebody makes a decision to open 2 opioids for a case, you have almost an 8 times likelihood of having a waste event. We think, based upon data from MPOG, that this generalizability of single centers predictors is high, and there's only a 10% observed variance between various hospitals for drug utilization in the operating room. So in summary, unit dosing, you see them in about 50% of intraoperative opioid doses. Waste is 8 times more likely when more than one opioid is used, and there is some cost associated with it. So what are the barriers for change? One is the fact that unit dosing is very convenient, right? Early in the day, I was talking to various people, asking them, how do we end up with 1 milligram of hydromorphone or 100 micrograms of fentanyl as our standard in the operating room? Or in some places, it's 2 milligrams of hydromorphone. It's because we were taught by people to use that. And they were taught by people who are now dead, with no evidence to support any of our sort of behaviors over time. So in fact, the work that Patrick and I are presenting here are one of several, I hope, in the coming years, and I know Chad's group has done some of this as well, that will help us identify what we should be using in patients, right? So what if we could influence clinician prescribing and dosing behavior so that we improve the quality of care and reduce complications? For example, first, let's look at what happened when Mass General tried to standardize RTA syringe neostigmine. And I was part of this paper, Alex here, maybe, yes, Alex on this as well. This is a great example of how you can introduce change in a holistic way. There's an entire intervention here, which includes, one of them is change from vials or previously uncontrolled neostigmine preparations to a 3 milligram neostigmine ready to administer syringe. And they also distributed these cognitive aids, had education, and built in a 1/4 of QI bonus into the salary. And the analysis was about a year's worth. And what they found was the mean neostigmine dose decreased during the period, no surprise. There was a decrease in excessive neostigmine dosage, which has been shown to be deleterious for patient outcomes, and they had better TOF counts at the end of their cases.
An outcome, this is where the money is. There was a 25% reduction in postoperative pulmonary complications during the study period. Their hospital length of stay was reduced by 10%, and their costs were reduced by 5%. All right. Here's a second example. Here's from Brigham here in Boston. There was a period of time when they were using 2 mil, just like most of us, fentanyl, and then there was a shortage. So for about 12 weeks, they moved to a 5 mil fentanyl vial, and then they went back to 2 mil fentanyl syringe. And guess what? When they went up to the 5 mil vial, just like Chad showed, he went back for a second helping, didn't he? And then when it went back, dosing changed. So I'm not saying that we're easily influenced by things around us, but it's pretty clear that the reason why we are using opioids with the doses that we're using them in is because of how they've been presented to us over time, and that can be changed, right? So much like many others, and I'm going to talk about what a high impact intervention is, I'm going to suggest here, and these are just my suggestions, with my conflicts of interest to go with it. I'm funded by Fresenius, so take this with a pinch or a sack of salt as well. But based on all the data that you've heard, not just from me today, I would suggest that choosing RTA opioid products over vials becomes really important when you're trying to standardize intraoperative opioid administration. The second is to consider patient outcomes and cost of waste. So really, we should be thinking about moving to 50 micrograms fentanyl for outpatient. We're going to focus on outpatient surgery because it's actually 80 to 90% of our work right now. And if we're thinking of hydromorphone, really begin to think of less. Now, I'm going to say that you're going to hear differently from Patrick, but I think this work needs to carry on for us to begin to understand, how ultimately it needs to be prospective to identify whether or not we're going to have a positive impact on patient outcomes. Lower impact actions that really think about educating clinicians to choose the RTA size depending upon where you want to use it, and then educating clinicians to use one opioid. And finally, all this is great, but unless you've got a mechanism to measure and report back, there's something that Michigan did very well with Chad's stewardship around the work with opioids. Unless you're able to show people that the things that you're doing have beneficial effects, you really don't get far with continuing this sort of work. So you want to make sure that you've got working with the healthcare quality groups in your hospitals to build the dashboards that you need to demonstrate improvements or not, right? Even if it's true that reducing intraoperative opioid dosages is bad, we actually need to be able to say, show that and stop doing what we're doing. Right now, we just change things with no idea of their effects on patients. So key takeaways are really that intraoperative opioid dose restriction has clinical outcome implications. And so you can either choose that to be positive or negative. The evidence supports the use of standardized opioid RTA sizes as an effective way to influence administered dose and opioid waste or cost. And I really want to exhort you to consider the strength of your intervention when you're making change. Be bold. You're not going to make the change that you want with clinicians unless you build in forcing functions for the behaviors. Thank you.
I want to thank our panelists today for an outstanding session. Very thought-provoking. Might I prevail upon, for a few minutes of questions? I know we're at our time. Can we go 5 more minutes?
Yes, absolutely.
We're going to go 5 more minutes for questions. And panelists, please use the microphones. There's one there. And why don't we get started? Elizabeth, get us kicked off.
First of all, thank you. It was an excellent panel. And my question is for Dr. Ramachandran with regard to the single-use fentanyl syringes. And one thing that crossed my mind is drug diversion. And it's more difficult in terms of drug diversion to withdraw the medication from an RTU syringe and then refill it. Not that drug diversion can't happen, but has there been any thoughts about looking at what you're doing with the smaller RTU syringes and how that impacts drug diversion?
Yeah, I think it's a great question. it actually it goes back to the question of how we're defining value with any of these interventions. One way to define value is reduction in chronic pain. It's an important one. Another way to look at it might be the improvement in respiratory outcomes, which are instantly costly to hospitals, right? And a third way is to look at the regulatory aspect, which is what you're talking about. There's a huge burden on clinicians for waste. And whenever there is an opportunity for waste, and Rita can back me up on this, there is an opportunity for diversion. So the closer your dose is to the full dose or the appropriate dose for your patient, the less likely there is diversion. That's first. The second is when you use RTA syringes, ready to administer syringes, I don't know if you're less likely to divert the syringe contents. Maybe Angie or somebody from Fresenius can answer that. But because you're looking at smaller aliquots, it's less likely, I guess, that a part of that will be diverted.
I mean, the thought that it's more cumbersome for someone that wanted to divert, to withdraw that medication and then fill that syringe with saline
something else
in an area where there are cameras in the OR and such. That's where the question came from.
Yeah, the concept is that with ready to administer syringes, you are moving clinicians into a space where they are simply using that drug for that one episode of care. And if they need another one, they're going to take another one for, the next dose. That's really where the value is, yes.
Dr. Fullen.
Yeah, great panel. Thank you. Enjoyed all the talks. Question for Dr. Brummett. So the steady satisfaction scores are interesting as the opioids have gone down. A lot of strategies have been applied to try to facilitate that. Multimodal pain therapy, for example, and also, more importantly, setting expectations with patients so that they maybe take less opioid. I wonder if you can comment on the extent to which those strategies you think have contributed to the results that you're able to get in Michigan.
Yeah, thanks. And I will say, if we had more time, I could have shown a lot more data. But yeah, I think one of the most important things we did was to start help surgeons in particular frame expectations, right? We've all had the surgeon that came in and said, you're going to be pain-free. And that's a challenge, right? And then we've had the other surgeon who came in and said, pain is a part of your recovery. Opioids are a tool. They are not painkillers. They are a tool, right? They're there to help you. When you say painkiller, you ascribe overwhelming benefit to that opioid. So opioids are a tool. They're not the only tool. And I think that, framing those expectations, but I will come back to, I think, satisfaction has been a bugaboo in our specialty for a long time. We do interventions that clearly improve pain, clearly improve opioid consumption, and satisfaction stays flat. So I was less compelled by that, but I think it's an important metric to look at. I think that the lack of change in pain was what really moved me. And I think some of that's expectation too. We're doing trials right now looking at how we get people to better utilize things that we know are effective, like acetaminophen and ibuprofen. But as I said, we definitely stayed away from people's favorite multimodal protocol. We didn't say whether or not we thought certain local anesthetics were effective or not. We just let people do those things. But framing and setting expectations for patients is critically important.
Sesh.
Hi, Sesh Madumbai, Stanford University and VA Palo Alto. Thanks to all the panelists for a great set of presentations. This is for any of the panelists. We're starting to see the emergence of transitional pain services to help manage postoperative opioid risks. My question is, what kind of preoperative interventions do you think, such as opioid tapering, could potentially help either clinician or patient, responses, either intraoperatively or postoperatively, any of those aspects? Thanks.
Yeah, probably you, Chad.
We don't know. And I think this is really a problem, right? So I got to tell you, transitional pain services, we just put an article in Rapam where I kept running into headway with our hospital administration I feel like a kid with a skateboard and I can't do any tricks. I go all over the country and I describe all our opioid work, but we don't have a transitional pain service, right? So this is something I can't describe from personal experience. We're launching a pilot right now and we're going to actually measure outcomes, but we have some folks who have done this and done it apparently well for a long time. And we're starting to see a trickle of data out of the VA in Utah. We've seen a little bit of data out of Toronto, but we have some well-described transitional pain services that have yet to come up with great patient-reported outcomes. And I can tell you a scaled-back version of a transitional pain service is about $1 million a year. That's a thin version of a transitional pain service. It's about $1 million a year. I believe, and we've looked at this, you can recover that because most of the potential recuperable costs would be in decreasing length of stay. We think about readmission, we think about ER visits. That's actually a small portion when we went back and actually looked at data. I think if we could reduce length of stay, say every third patient went home a day sooner, we would recoup that. And then we need to know, I'm not confident that opioid weaning is the way forward. I'm not, because I think ultimately we will never find surgeons or patients that are willing to wait long enough and have the people off that opioid for long enough or reduced for long enough to have a meaningful effect. And certainly what we don't want, and we all experience on a daily basis, is somebody coming into the operating room in acute withdrawal because their surgeon told them they need to, and now you're in a worse state of a hyperalgesic patient who's in withdrawal and you're playing catch up. So I think there's a lot of need for work here. And by all means, if other people want to do this work, there is need for this work.
I'd like just to comment a little bit on the Utah experience in the transitional pain service. We do have a federally funded VA transitional pain service, and that greases the tracks, but it is a very small piece of our overall patient care volume. And we've tried to adapt that to our regular main hospital, if you will. It's a total Robin Hood. We just take clinical income and we redirect it at our TPS to keep it alive. I will say this, though. One of the potential benefits that I see is it helps perhaps minimize the risk of relapse, which maybe doesn't have a monetary value, but it has a devastating effect to these people's lives. And so just that alone, when I meet these people, I'm like, this is probably worth our Robin Hood effort.
So it's interesting because you just brought this up. Who's paying the money out in the hospital for the drugs or for the service, and who's generating the money, right? So often the people paying the money for these drugs are the pharmacy, the pharmacy bucket. And if people are admitted to the hospital for a day longer or not, it's a different group, the hospital group that, the billing people. And anesthesia is just the user in the middle, right? So we're not actually experiencing the pain of the costs or the pain of the complications, either way. But it's an interesting problem is how you actually get organizations to be holistic about this.
Dr. Warner.
So Ken, Mark Warner at Mayo Clinic in Minnesota. Dr. Stoelting apologizes. He's not here today. He's unable to travel, but he says, thank you all for being here today. And he also says he remembers Chad coming down to his office.
Yeah, right.
Very proud of what Chad has accomplished, but for the life of him, he cannot understand why the hell he's a Wolverine.
Drink some Chad today.
We should end with that question, I think. No, I have a question about remifentanil. It's to any of the panelists. Thank you. Trish Mack from Cornell. Everyone in my department seems to start out with 2 cc's of fentanyl and then run a remifentanil infusion and then give some dilaudid at the end because, the remifentanil is going to wear off. And sometimes I end up tearing my hair out with 3 different drugs to waste at the end of the case. And I was wondering if anyone wanted to comment on the use of remifentanil.
Yeah, I had a mini seizure then. Sorry. Bad for my OCD. Just hearing that. I don't know. I mean, remifentanil, this is a problem, right? So we as anesthesiologists, we love our rituals. And it's so interesting why we choose the things that we do. I've come to believe that there is no precision in how we do things. It's precision centered on the clinician. It's not precision centered on the patient. So we have perhaps 3 or 4 different kinds of things that we do for patients. And there is a particular dosing we have in mind for each of these things. So for that person who's using these 3 drugs, they were unfortunately taught that this is the appropriate thing. How are you going to unlearn that if you are the one doing it? I think it's a very difficult, because we love, for many reasons, and Amy, this is probably one of the PTSD, the complex PTSD side effects. I own this. I love the way I give my anesthetic. Don't take it away from me, right? So it's interesting. What is the value add for an anesthesiologist to say, I'm not going to do this and I'm going to do that? We really have to start thinking about the value proposition for the individuals to change their dosing behaviors.
Well, I think that's a wrap. I'd like to once again thank our panelists. What a great session. Appreciate it.
Thank you all. It's been a very thought-provoking day. We have our reception that'll start at 6 p.m. tonight in the second floor of the hotel. Please join us. And then tomorrow, breakfast is at the hotel from 6 to 7:15, and we'll start here at 7:30. So we'll see you all tonight and then tomorrow at 7:30. Thank you.